All right, we're gonna go ahead and get started. We are having a few technical difficulties, but our very competent AV team, I'm sure, will sort it out before we're ready for that piece of talk. And if not, we will adjust because what else can you do? All right, so welcome. Thank you so much for coming to this session. DEI is such an important topic and continues to be such an important topic given our social climate right now. So I'm happy that we are all here to learn and advance our understanding in this area. So my name is Christina Pierre. I'm a moderator and a speaker. I'm a clinical chemist at Penn Medicine Lancaster General and a clinical assistant professor at the Hostel of the University of Pennsylvania. In my ACC capacity, I'm the chair of the DEI committee, and I'm also the marketing and sponsorship coordinator for the Health Equity and Access Division. So I spend a lot of time thinking about both health equity as well as DEI. So to start off today's talk, I'm not going to go too in depth as far as defining race as a sociopolitical construct versus a genetic construct, but suffice to say that we know now that historical views of race in terms of using it to delineate distinct biological categories have been largely debunked through the sequencing of the human genome. Historically, we thought that race was heritable, innate, and fixed. There were also some very ugly and racist ideologies of racial inferiority of non-European or non-white groups, which were used essentially as a justification for slavery. So the way that we understand modern-day race, unfortunately, was found in the context of the United States and in much of the Western world, unfortunately, was founded out of a need to justify enslavement of people originating from Africa. We also know that during the Enlightenment period, those social ways of thinking seeped into science, unfortunately. And then you had many polygenists that essentially promoted theories that differences between races could be explained by genes. So currently what we know is that race is a social construct. We also understand now more than ever that systemic racism causes downstream effects, right? So we know that there's differential allocation of resources, differential allocation of social and healthcare resources. And we know for a fact that those resources and that differential allocation therefore has an impact on outcomes and health that are experienced by minoritized people. And this is not necessarily limited to racialized minorities. We also see this, for example, in marginalized gender minorities as well. And finally, as I mentioned before, we now have a very good appreciation of the fact that race doesn't capture, it fails to capture genetic variation. So the idea that social determinants of health or socioeconomic factors have an impact on health is not a new one. There have been sociologists such as W.E.B. Du Bois who has been studying this for quite a while. So back in the 1900s, W.E.B. Du Bois was commissioned by the University of Pennsylvania to study Black people in the Philadelphia area, and he documented his findings in a manuscript called The Philadelphia Negro. And one of the things in this manuscript that he noted is the fact that racial differences in mortality in the context of Philadelphia could be explained by a number of different factors, but he did attribute a lot of the differences in racial mortality to social factors rather than innate racial traits. So he touched on the fact that discrimination, systemic racism, and oppression and racist policies contributed to elevated levels of despair, so differences in mental health and well-being, as well as physical health and death amongst Black individuals that were studied in the context of Philadelphia. So when we talk about race and using race in medicine, what we're essentially talking about is the impacts of racism, right? So thinking about moving away from describing race essentially as a determinant of health and thinking about putting it in context of race being a determinant of racism and therefore that leading to differential outcomes in health. So race essentially captures the impact of systemic racism, right? So this leads, as I said, to differences in allocation and access to healthcare, as well as the quality of the healthcare received. So based on this understanding, and this is why I decided not to go too in depth into this, because I think that this is now established fact, right? That we all understand these principles pretty well. Thankfully, we've come a long way in medicine in terms of our understanding of how social determinants of health influence disease processes and health in general. I think the next step that we now have to take is now as scientists, so we are not social scientists, right? We are classically trained basic scientists and then clinical scientists. So the next step that we have to take now is to think about how we can incorporate those environmental exposures that result from systemic racism when we look at biological and clinical processes, right? So how do we then take into account the fact that there are differential exposures, there are differential experiences, and differential what we call allostatic load that results from cumulative effects of experiencing racism and experiencing differential social determinants of health across the lifespan of an individual. The National Academies of Sciences, Engineering, and Medicine recently issued a consensus report on the use of population descriptors in genomics research. They issued 13 different recommendations, and I'm going to summarize a few of them here, which kind of gives us a roadmap of how we can actually start to, as scientists, how we can actually start to look at environmental exposures in our research as causative for some of the health disparities that we see. So the first recommendation talks about discontinuing the use of race as a proxy for human genetic variation, right? So it's common practice when we in medicine and science to group people by race. And I guess the issue with that is that except for looking at health equity data, and except for using that data to determine the sources of health inequity, it's really not appropriate to use race as a proxy to describe different groups, right? So this is a concept that a lot of people struggle with. And I talk a bit about this in my talk on EGFR, which will follow this depending on how AV is doing. But, it's going back to thinking about seeing racial differences in health and racial differences in disease and observing those which are valid observations, but then asking the question, why are they different? And not making the assumption that genetics is the reason why they are different. They also talk about the avoidance of typological thinking. So in other words, the assumption that there's some sort of implicit hierarchy, that populations are homogeneous, distinct categories. We already talked about that. And also being attentive to the connotations and impacts of terminology. So I think that this is something that I think sometimes is kind of glazed over in terms of when we're talking about racial health equity in the context of medicine, right? But the reality of the situation is that if we're using terminology and if we're using categories that were originally meant to oppress people, that does have a social impact. That does have a lot of social meaning that I think we need to think about and be cognizant of. So the National Academies of Sciences recommends that we start to evaluate the environmental factors and exposures rather than using population descriptors such as race as proxies. And then also, if you are using those descriptors in your research, you should describe how and why those descriptors were used and disclose the process and rationale for selecting and assigning any group labels that you use. Similar guidance has come out from a number of different organizations. So the MA Manual of Style, issued guidance on reporting of race and ethnicity in medical and scientific journals with the goal of reducing unintentional bias in the literature. So they recommend that researchers provide balanced evidence-based discussions of the implications of essentially their findings in the context of systemic racism. And they go as far as to recommend that you should use specific words, right? So it's no longer taboo for us to talk about racism it was never taboo, I think, for minoritized racial groups to talk about racism, but I can see how it's uncomfortable for non-minoritized racial groups to talk about racism. But we're encouraging us to start to do that. And the AMA Manual of Style says that you can use those words specifically and encourages you to use those words specifically. They also recommend a number of or issue a number of recommendations on the language that you used. So I'll just touch on a few examples. So rather than using the general term minorities, you should add a qualifier, so racial minorities or gender minorities, or the way that I prefer to phrase it is minoritized people. So these are not people who are inherently minorities. They have been minoritized by systems of power. And a number of other recommendations around some of the language that we can use to describe minoritized groups. So I wanted to use that to set the stage for our discussion today. So today's talk is focused on how we can use our knowledge, our improved knowledge of systemic racism and social determinants of health to advance healthcare equity in the context of medicine and in the context of the clinical lab. Our first talk, AB, are we good? Yay. I'm gonna clap. You guys are so awesome. Thank you. If you were not here, this session was not going to happen. Okay.
And I.
Okay, great. So our first talk today has actually been pre-recorded. So it's by Dr. Esther Davis. Dr. Davis would have loved to have been with us today. She actually recently transferred faculty positions from the University of Pittsburgh to the University of Maryland. She's a professor of medicine, visiting professor of family and community medicine, and the associate vice president of community health, Senior Associate Dean of Population Health and Community Medicine at the University of Maryland School of Medicine, and the lead health equity strategist for the University of Maryland Institute for Health Computing. She is also the director of the Transforming Biomedical Research and Academic Faculty Through Opportunity Training and Mentorship Program. There's a lot more that I could say about Dr. Davis, but I will let her go ahead and start her talk, which focuses on the actions that the U.S. Preventative Services Task Force has proposed to mitigate the effects of systemic racism in clinical preventative services. Do I have to do something here? Okay, y'all.
I am a member of the United States Preventive Services Task Force, and we'll be talking to you about how we at the United States Preventive Services Task Force are working to mitigate systemic racism in our clinical preventive services. So my disclosure is that I am giving this presentation on behalf of the United States Preventive Services Task Force, and also if for our current methods and recommendation statements, please visit our website. My objective after this talk, you will be able to explain what the United States Preventive Services Task Force is and does, and explain the United States Preventive Services Task Force recommendation statement development process, and also be able to describe the approach that we're using to mitigate racism and ensuring health equity within our preventive services recommendations. I want to begin with just a brief overview of what the USPTS TF is and what we do. So our mission of the United States Preventive Services Task Force is to work to improve the health of all people in the United States. We were created by Congress in 1984 to make evidence-based recommendations on clinical preventive services and to improve the health for everyone in the United States population. And that our evidence-based recommendations focus on screening, behavioral counseling, and preventive medications. So this is a slide of our current USPSTF members. We are an independent group of non-federal volunteer experts in primary care prevention and evidence-based medicine. We constitute 16 members, including 1 chair and 2 vice chairs. We serve a 4-year term, and we're appointed by the AHRQ director with input from the chairs and the vice chairs. We undergo a continuous rigorous conflicts of interest review process. And we have partner organizations, both primary and specialist partners that provide input to ensure accuracy, relevance, and dissemination of our recommendations. I wanted to say a little bit more about our partners because they're extremely important in helping to provide input on recommendations and facilitate dissemination and implementation. They represent a wide constitution of organizations and the individual primary care clinicians, the consumers, and other key stakeholders, and of course, our federal agencies, such as NIH, CDC. They help the task force ensure that our recommendations are useful to clinicians and are implemented into clinical practice. And they support the task force as we work towards keeping America's primary care workforce up to date on USPSTF recommendations. So here's just a snapshot of our many partners that we work with. So partners who support primary care delivery, such as the American Academy of Family Physicians, partners that focus on healthcare utilization, coverage, and quality, such as America's health insurance plans, partners who develop recommendations on prevention, work very closely with the Community Preventive Services Task Force, and then, of course, our federal partners, the CDC, the NIH, the FDA. Now, the Agency for Healthcare Research and Quality, which you all know is an agency within the United States Department of Health and Human Services, provides administrative, scientific, technical, and dissemination support to the USPSTF. However, the USPSTF is an independent entity, so it is not a government organization or part of a government agency, while it does receive support from ARC. And it's an important distinction because we often in our coverage of the USPTF task force get confused as being a government agency. And ARC's mission is to produce evidence to make healthcare safer, high quality, more accessible, equitable, and affordable, and to work within HHS and with other partners to ensure the evidence is understood and is used. So what is it that the USPSTF does? So we make evidence-based recommendations about clinical preventive services that address only services offered by primary care in the primary care setting or services in which are referred to by a primary care clinician. Our recommendations apply to both adults and children with no signs or symptoms of disease or have unrecognized signs and symptoms. They are also based on rigorous review of existing peer review evidence. So we do not conduct any clinical studies, but we do conduct systemic reviews with in partnership with our evidence-based practice centers. And we evaluate benefits and harms of each of the service based on factors such as age and sex. So now I just want to spend just a brief moment on our recommendation development process. So our process begins basically with topic nominations, and anyone from a individual in the community to an organization can nominate a new topic for review by the USPSTF at any point in time. And we have a really nice process for doing that on our website. And then and we review these topics and update them regularly. We then will review the nominated topics for relevance and impact, and of course, relevance to primary care and public health. And then we will select and prioritize those topics and develop in conjunction with our evidence-based practice centers. The next step will then be to develop a research draft plan. And so once our evidence-based practice centers develop that research plan, then we will then seek expert input And then we will post that draft plan for public comment. And this is one area where anyone, and we encourage all of our partners to make comments to that draft plan during that time. And so then we will review those public comments and finalize the research plan. And then the next step will then be our evidence-based practice centers then goes off to um, analyze the data or obtain the data, analyze the data from conduct the systematic review. And then they will then bring the completed review with the evidence back to the task force. We go through a period of evaluating and deliberating over those, over the review, over the data. And we then will come up with our draft recommendation statement based off of that evidence review. And then once that happens, we have another step where there's public comments. And so we will post that draft recommendation statement and again, welcome all to give input at that point on our draft recommendation statement. We will then take that down, we'll take that back, review all the comments, and revise and finalize our final recommendation statement. And then that final recommendation statement, along with the evidence summary, gets posted to our website and also gets published in a peer-reviewed journal. So all of our topics, all of our recommendation statements are based on the analytical framework, which is also published. This is just a generic framework to give you a sense of how we then consider the evidence review based off of the framework. So they all start with a focus population on the left, again, usually people without signs or symptoms of the condition for the recommendation statement. We then have and again, the setting is primary care. And then what we do is we consider evidence, what we call as the direct pathway or key question data. And that is, in this example, whether screening will reduce health outcomes, right? So we consider this direct evidence. Are there randomized controlled trials that look at screening and show that they make a difference in some health outcome? We also then will also consider evidence along what we call the indirect pathway. So screening, and then trials that look at the harms of screening. And then once screening reveals a result, then usually there's some kind of diagnostic evaluation that makes the diagnosis. And then they also have to get treated. And then that treatment leads to the health outcome. And usually there's evidence along this entire pathway linking it together to show that screening will make a difference in the outcomes. And then what we do is basically consider the magnitude of the net benefit and the level of certainty that we have based off of the evidence to conclude. So this is an example of a screening analytical framework for screening for atrial fibrillation. And as you can see, what we consider for these for the direct pathway are questions such as, does screening for AF improve health outcomes? And then again, key questions along this indirect pathway that help to provide the evidence for this linkage. So I just want to spend just a second on how to read our recommendation statements. So we assess the evidence again across that analytical framework that I just showed you. And we judge the level of certainty of the evidence that we have of a potential benefit or harm. And we rate that benefit or that certainty as high, moderate, or low. And then we also consider the magnitude of a potential benefit or harm. And we will rate that as substantial, moderate, small, or zero. And our judgment is really in the balance of the benefits and the harms, or the magnitude of this net benefit is what we're really assessing. And so when we establish that the certainty is moderate or high and the magnitude of net benefit is moderate or high, we give it a grade of A or B and recommend that this recommendation gets implemented and done routinely in clinical care. When the benefit is small, with a high degree of certainty in the evidence, then we will rate that evidence as a C and say to do that selectively through shared decision making. And then if we find zero or negative net benefit, then we rate that a D, which is do not do it because the harms outweigh the benefit. And then, of course, we have our I statements, which says that there is insufficient evidence to determine whether or not there are substantial benefits or harms to make a recommendation. And then, oops, sorry. One of the important things about our recommendation statements that, we often get the question of why do our recommendations differ from other organizations? And it's because we do not use consensus or expert opinion. We only rely on the evidence to make our recommendation. And then just as a side, under the Affordable Care Act, it requires that insurers cover our A and B recommendations without cost sharing. So even though we do not make, cost, any kind of cost decisions in our recommendation statements. All right, so now I want to spend the rest of the time really talking to you about what we've done in our effort to achieve equity and preventive services. So we are committed to helping reverse the negative impacts of systemic racism on health. And over the past several years, we have really shifted from our focus on race, which we've always considered in our evidence and in our guidelines, to more of a focus on racism and the effects of racism, and particularly recognizing that health inequities are due to social, economic, and structural factors, and that we are constantly developing strategies to mitigate the influence of systemic racism and preventive services recommendations. So we did an audit and we looked at where we were currently addressing social risk in our recommendations. And as you can see, with regards to food insecurity, transportation, and utility needs, we did not have any current recommendations that had made any reference to the social risk. But we do have recommendations that have referenced housing instability or interpersonal violence, education and financial strain, or non-target social risk domains, such as in our prostate cancer screening. And so in 2020, we created a task force work group to specifically focus on race, racism, and health equity, and to help us come up with efforts and initiatives to ensure that we were addressing health equity and across all of our recommendations and at every step of the process. So we first commissioned a report, our evidence-based practice centers, to do a comprehensive report, which they completed in June of 2021, and can be found at this link, which is also going to be in your handouts. And we had two main aims of this report. Aim one was to articulate the definitional and conceptual issues around racism and health inequities, specifically key terms, concepts, definitions, and how did racism produce health inequities, and what were the mechanisms of action. And then aim two focused on describing how racism and health inequities are currently being addressed in preventive health. So how are race, health inequities, disparities addressed in our current portfolio? We asked them to look at what types of interventions reduce health inequities and disparities by race. And then we also asked them what types of interventions directly address racism in healthcare. And they produced a very comprehensive report for which we were able to then create two additional articles and a viewpoint that outlined the first steps to create the change in how we recognize and address systemic racism in our clinical preventive services. And both of these are available. So these were the 6 points or the 6-step action plan that we laid out in those articles. So first, that we would consider race as a social and not a biological construct, that we would promote racial and ethnic diversity and membership and leadership and foster a culture of inclusivity, that we would then commission a report, the one I just mentioned, to understand how systemic racism undermines the benefits of evidence-based clinical preventive services, developing a process in which we are iteratively updating methods to overcome health inequities experienced by populations that are affected by systemic racism, that we are able to better communicate our gaps that are created by systemic racism in all of our recommendations, statements, and in our dissemination efforts, and that we continue to collaborate with partners and experts in a way that reduces the influence of systemic racism on health. And so I just want to go into a few of these a little bit more detail and give you a sense of where we are to date in our progress. So the first thing we did was we, again, with the help of our evidence-based practice centers, commissioned them to help develop a health equity framework for our recommendation development. Now I'm going to talk about that in a little bit more detail in the next slide. Looking at processes for incorporating social risk factors into our analytical framework and in our research plans, continue to always foster a culture of diversity and inclusiveness. We have been working to adopt inclusive language and are in the process of developing an inclusive language guide, addressing algorithm biases, promote evidence-based implementation strategies, and of course, always working to seek input from our partnerships and of course, the role of the public. And so just in terms of our health equity framework, which has been developed now, and it is being used to guide some of our pilot work in incorporating health equity, race and racism into our recommendations. And so this framework, very comprehensive, provides us a checklist of key items to consider at each stage of our process, from topic prioritization, development of the work plan, evidence review, the evidence deliberation, and on down to development and dissemination of our research statement. And then, of course, again, being more intentional about where we seek input from our partners. So this is just a snapshot of the 10 health equity pilot projects that we have currently in progress. Some are screening recommendations, some counseling, and where we are with piling these different pieces that I just mentioned into our recommendation statements that you will then see will start to look different. So the first thing we've done is incorporated contextual questions in our analytical framework. So when I showed you the analytical framework, I mentioned that we focus on key questions, and those key questions are which the systemic review is based. But we've also incorporated what we call contextual questions, which I'll show you an example of in a second. And these will specifically help us to address health inequities across different populations, the drivers of these health inequities, and then interventions to reduce health inequities. And our next steps that we're working on right now is continue to develop a framework for incorporating our contextual question information into our recommendation statements. We are first piloting this with our screening for hypertension disorders of pregnancy, which a draft recommendation statement was posted in February. And we are also adding language to, we have, so when you look at our recommendation statement, we have a preamble to them, and we have now included language around ensuring health equity. And so this is just an example, and it's in the handout. I won't read them. I put them in the handout for you to review. But just to give you a sense of the general areas that our contextual questions for some of the pilots have been asking. So, for instance, how racism, social inequities, unequal access to quality healthcare, and other factors contribute to existing inequities, disparities, and incidence and outcomes, right? So these are just generic, but we've made them more specific to whatever the topic we're working on at the time. We also included this new language, which has been added to our preamble of our recommendation statements. And again, I won't read it, but I did put it in your handout to review. But it's basically language that says how we are committed to mitigating the health inequities that prevent many people from fully benefiting from our preventive services. Also, we are piloting in our breastfeeding draft research plan, which was posted back in the spring. We have been working with uh, various ways of highlighting our approach to health equity in our research plans. So we've added a new paragraph below the key. So we have usually key questions, and our contextual questions are detailed. And then we added a new paragraph below that detailing how we plan to synthesize the evidence for specific populations. And it's going to be under a section entitled Approach to Assessing Health Equity and Variation Across Populations. We also have been piloting a new section in our recommendation statements, which you may have seen in our recently released screening for anxiety disorders in adults recommendation statement. So usually you'll see the recommendation summary with our grade. And then now we have this new box that will appear just under that, just under what we call the top line. And it's the pathway to benefit, because we realize that even though we evaluate the evidence, in this case for screening for anxiety disorders, something else needs to happen after that in order for the patient to fully benefit from the recommendation. And so we have added that. So we say to achieve the benefit of screening for anxiety disorders and to reduce disparities uh, associated with morbidity, it is important that persons who are screened positive, right? So that's our recommendation. They have to be screened. But then what next needs to happen? Well, if they're screened positive, then they have to be evaluated further for diagnosis, and then, if appropriate, referred for evidence-based care. So just helping to follow through on what would need to happen. What would our partners need to do on the other end, right, to carry out, ensure the full benefit, the patient receives the full benefit of our recommendation statement. And so this is a new section that you will see added. And then we are also addressing, which I know, you as an organization are also addressing, and that's this racial bias in algorithms and risk assessment tools. And so, we have been prioritizing developing methods to assess algorithmic bias of prognostic clinical prediction models where race is included as a predictor or a stratifying characteristic. And so in these models, we refer to these models as race aware. And our algorithmic bias refers to issues related to model design, data, and sampling that may disproportionately affect prediction model performance in specific populations. And whereas fairness in the context of risk modeling refers to whether algorithmic decisions create discriminatory or unjust impacts when comparing against specific populations. So one of the things that we've been thinking about in being able to also help us address race bias and algorithm risk assessment is to consider at times when to use non-randomized studies of interventions. And so our Evidence-Based Practice Center has recently presented a comprehensive report on non-randomized studies of interventions and extrapolation. And now we are developing a guidance for when it may be helpful to consider these non-randomized studies of interventions to support our top-line recommendation for specific populations. So that is in progress. And we also, just to review very quickly, developing an inclusive language guide with in collaboration with our communications team, our ARC staff, and members of our task force to come up with a guide that will inform all of our communications and our dissemination and implementation that makes sure that we are using the most inclusive language. We are always welcoming new D&I partner organizations or their representatives to improve stakeholder input. We are constantly reflecting on our governance and our culture within the task force, our membership. And I should say that for task force membership, anyone, as with topic prioritization, can also nominate members to the task force. And there is a process for that on our website as well. And any nominations are then reviewed by the chairs and the vice chairs and the art director to see if they are able to serve. And then we are constantly presenting to our various organizations, such as the CDC, NIH, about our equity initiatives. And then we really value feedback on our initiatives from our partners throughout our entire process. So I just wanted to give you a quick snapshot of our recommendation statements that were recently published by us over the past year and are also in progress. And I selected these just to highlight where your organization may be very helpful in providing input and certainly ones that are applicable to the work that you do. These recommendation statements really involve diagnostic laboratory values. So our latent tuberculosis infection in adults, our recent serologic screening for genital herpes infections, and then the ones that are in progress as our breast cancer screening. We have one on chronic kidney disease, which I'm aware that you all have worked closely with looking at GFR. And so, for these ones that are in progress, it would be very helpful when our research draft plans are posted or our draft recommendation statements are posted, that you go on to review them and that you weigh in, particularly from this very important diagnostic point of view. And finally, I just want to talk very briefly about what we're doing to better communicate our evidence gaps for future research, because oftentimes this is where our recommendation statements are also very valuable. So one, they're valuable in providing the evidence and recommendation for clinical practice. But the other part that's really important about our recommendation statements are usually the call for more research. And particular types of research that will help us in instances when we have I statements to help move us off an I. And so to fulfill our mission to improve health by making evidence-based recommendations for preventive services, we routinely highlight the most critical evidence gaps in our recommendation statements, and they're presented in the research needs and gaps section of each statement. And they outline the critical evidence gaps that are summarized, or I should say the critical evidence gaps that are summarized by the task force in an annual report that then gets presented to Congress. The National Academies of Sciences, Engineering, and Medicine issued a report in a taxonomy, and the purpose of this report and taxonomy was to assist the task force in classifying and prioritizing our evidence gaps. And so we are currently in the process of applying elements of this taxonomy to our process for identifying evidence gaps. And the goal of this, which you will be seeing in the very near future in our recommendation statements, is to better inform researchers, not just calling for more research, but really informing researchers on the types of studies and the particular things to focus on to address the evidence gaps. And so this is detailed more in a recent viewpoint that we put out. And there's a link in your handout to the full report, and I encourage you all to take a look at it. So to summarize, the USPTSTF we are being intentional about health inequities and structural racism. And we are continuing to work toward advancing unbiased evidence through inclusive research. We are addressing our gaps in evidence base for preventive services, and we are continuing to be aware of built-in biases in the current evidence base and algorithms and risk assessment tools, and working to address as best we can in our deliberations, and then advancing health equity and guideline development process from topic prioritization all the way through to the final recommendation statement. And with that, I thank you all for listening. Please feel free to contact me with any questions, or of course, you can contact us at this link here, and also find additional information about all of the things I talked about today. Thank you very much.
So we regret that Dr. Davis was unable to join us today, but we're very grateful that she shared with us. And again, please feel free to reach out to her with any questions that you have. Now we're going to pivot to focus a bit on a guidance document that was published in the July issue of JAM. So this document was written by the American Academy for Clinical Chemistry in collaboration with the National Kidney Foundation. And specifically, it was a group of members of the Health Equity and Access Division led by myself and Dina Green in collaboration with leadership from the National Kidney Foundation. I have nothing to disclose. So we know that historically, the two most commonly used equations to estimate kidney function, or to estimate GFR specifically, are the modification of diet and renal disease, the 4-variable version of the equation, as well as the CKD-EPI 2009 equation, and that both of these equations incorporate a race factor. And this race factor is specifically incorporated for African Americans, and everyone who is not African American does not have a race correction factor. So the question is why? Why was this race factor incorporated into these equations? So the authors of the study that created the basis for the development of these equations observed higher creatinine concentrations in Black participants of those study cohorts compared to non-Black participants. The majority of these participants were white for the same measured GFR. So in other words, they include a race factor with the intent to improve the accuracy of Black participants. And it's important to acknowledge, as I said in our introduction, that we do see racial differences in the expression, or in the, I should say rather, in the concentration of multiple biomarkers that we use in the context of the clinical laboratory. So the question is why, right? So in this case, the authors attributed it to differences in muscle mass. But as I mentioned before, we now understand that race does not define distinct genetic categories, and therefore we should be looking more at environmental and socioeconomic factors. So in other words, let's understand what it is that is actually causing these differences, and name it and call it that, and then research accordingly. So based on these premises, a task force of the National Kidney Foundation and the American Society for Nephrology issued recommendations based on a study that was performed using some of the CKD epi cohorts. You guys are probably all familiar with these recommendations. And they recommended that newly developed CKD epi equations that do not incorporate a race variable should be implemented. These are creatinine-based equations. That there should be national efforts to facilitate increased use of cystatin C, which is another kidney filtration marker, and further to encourage and fund research for new biomarkers for GFR estimation. So let's look really quickly at the new equations that were developed. And I'll start by describing the metrics that are used to assess these equations. So the first metric is bias, or absolute bias, and this describes the difference between measured GFR and estimated GFR using the newly derived equations. P30 describes the percentage of estimates that are within plus or minus 30% of the measured GFR. Typically speaking, in terms of a P30, 80 to 90% is considered acceptable and greater than 90% is preferred. And then lastly, they look at the clinical performance of the equation, right? So how many people are correctly classified? In other words, agreement of eGFR with mGFR categories using guideline recommended GFR stages. Typically speaking, 60 to 70% is considered acceptable, 70% is optimal. So looking at the new equations that were developed, on your right, you have the CKD EPI 2009 equation that incorporates age, sex, and race as demographic characteristics. They also experimented with an equation in which the CKD EPI 2009 equation was used, but with removal of the race factor. And then the eGFR creatinine, or the new equation, is the one that's race agnostic. So the demographic inputs are age and sex. For context here, in green, those participants self-identified as Black, and in orange, those participants self-identified as non-Black. So in this particular cohort, you can see using the CKD EPI 2009 equation, which is up on your screen, there is more bias in Black participants compared to non-Black participants. The P30 is approximately 85% in Black participants and 89% in non-Black participants. And the equations correctly classify people by CKD stage in about 63 to 69% of participants. Now, I'll invite you to focus on your leftmost graph of the screen, where you can see that the new CKD EPI creatinine-based equation, so the CKD EPI 2021 equation, has a bias that is equal, right? So it's 3.6 mils per minute per 1.73 meters squared in self-identified Black participants, and in non-Black participants, it's negative 3.9, right? So the absolute value of the bias is the same, it's just in a different direction. The P30 is about equivalent, about 87% and 86%, and then the correct classification is 62 to 67%. Now, one important thing to remember when we are thinking through the implementation of these equations is that there are advantages and disadvantages to the underestimation and overestimation of kidney function using eGFR, right? So if a Black race factor is applied as it is in the MDRD and the CKD EPI 2009 equations, then we have a higher eGFR in people who self-identify as Black, which then can result, for example, in a longer wait for a transplant, later CKD referral, and later dialysis initiation. Also, they can also get a higher dose of nephrotoxic drugs, right? And then the converse is true if you don't use this correction factor. I'd also like to point out here that the P30 gives you a good sense of the spread of values, or the fact that eGFR is really and truly an estimate, right? So we have to keep that E in mind. So the task force issued these recommendations, and we, as a group in the Health Equity and Access Division, really found that there was a need or a gap that was required to put the CKD EPI 2021 equations in the context of the racial health disparities and describe it to clinical laboratorians. We also wanted to highlight steps that clinical laboratorians can take to mitigate healthcare disparities in kidney disease. And we also wanted to highlight intersectionality, right? So the idea that people with multiply minoritized identities can have even worse outcomes than people with singly minoritized identities. So in that vein, we decided to incorporate a section that discussed gender. I'm not going to discuss that today because we are currently working on a manuscript that looks at that in more detail that will be published in AJKD later this year. And then we also provide guidance on cystatin C. So this is the dream team that wrote this guidance document. It's comprised of a number of clinical chemists. You may recognize many of these faces. And then the past president, current president, and chief medical officer of the National Kidney Foundation, as well as a patient advocate and sociologist who works in gender diverse populations. So starting off with, one of the things I wanted to highlight is thinking through what groups are at worst risk for kidney disease burden, as well as poorer outcomes from kidney disease. So we know we're very aware of what the clinical risk factors for CKD are, right? So your diabetes, hypertension being the two leading risk factors, as well as cardiovascular disease, obesity, and smoking. On the bottom here, you can see that there are also some other risk factors that you don't hear necessarily, I guess, discussed as much, race and ethnicity being one of them, right? So race and ethnicity are leading risk factors according to this diagram. We know that racism is a risk factor. Exposure to racism is a risk factor for developing kidney disease. It predisposes you to developing diabetes and all of these other chronic lifestyle-related diseases that then increases your risk for CKD. A really nice figure that illustrates I guess the differences in kidney disease health outcomes by race and ethnicity also kind of looks at socioeconomic factors, right? So this graph from the US Renal Data System 2022 report essentially shows the incidence of end-stage renal disease by race, as well as by what we call the social deprivation index. The social deprivation index essentially describes neighborhood level data on a number of socioeconomic drivers of health, for example, household income, et cetera. And so what you can appreciate here is that there are stark racial differences in the incidence of end-stage renal disease, with white people having lower incidence of end-stage renal disease compared to Black and Hispanic people. Another thing that's really noteworthy within this graph is that social deprivation, right, is also determines the incidence of end-stage renal disease, right? So you can see that in people in this cohort that have a very high social deprivation index, so more exposures, more risk factors, also have a higher incidence of end-stage renal disease. So you see this compounding effect of multiple minoritized or multiple marginalized identities, right? So low socioeconomic status compounding with race, or racism rather, to determine end-stage renal disease. So in the document, we describe how clinical laboratories can contribute to closing racial and ethnic disparities in CKD. So one of the major challenges that was highlighted by the nephrologists and by the NKF in terms of CKD is that many people are unaware of their disease, right? So detection is a serious challenge, largely because CKD is very silent, and often you become symptomatic in later stages of the disease where there are less options in terms of prevention and lifestyle interventions. So one of the asks from the NKF is that clinical laboratorians really help them to increase early detection and awareness of kidney disease in both clinically high-risk populations, so we know our diabetes and hypertension, but also socioeconomically high-risk populations as well. And there are 4 different ways that we propose doing this in the guidance document. So the first is standardization of CKD biomarker testing and EGFR reporting, optimization of test utilization and interpretation, using enzymatic assays in favor of Jaffe assays where possible, and providing cystatin C testing with a short turnaround time. From the perspective of standardization of CKD biomarker testing and EGFR reporting, we encourage your lab, if you have not as yet, to switch to the CKD EPI 2021 EGFR creatinine-based equation. In a study that was published in 2022 in JAMA, they used College of American Pathologists data to evaluate how many labs had implemented these new equations. At the time of that study, 76.9% were aware of the new 2021 CKD-EPI equations, and only 30.3% had already adopted the 2021 CKD-EPI creatinine equation. 34.5% planned to adopt it, and 58.4% were unsure. So we're still seeing really poor uptake of these equations, which is disheartening, but we would like to encourage you, if you haven't as yet, to switch to the CKD-EPI 2021 creatinine equation. So thinking through what tests are used to diagnose chronic kidney disease, we know that chronic kidney disease is staged according to the GFR, so CGA staging. So your GFR as well as your albuminuria and then chronicity, right? So we encourage you to implement a test called, or a test combination called the kidney profile, right? So the kidney profile essentially consists of creatinine or cystatin C along with eGFR, and then urine albumin creatinine ratio to assess albuminuria for albuminuria staging. One of the things that came up, again, from the nephrologist in this document is that the urine albumin to creatinine ratio is significantly underutilized. And this is for several reasons. There's very non-standardized reporting. So in some of your labs, you're probably still reporting microalbumin. What is that? And then often labs are reporting albumin not normalized against creatinine, which also is not useful outside of the context of a 24-hour urine collection, right? And then clinical uncertainty around the utility of the test and interpretation. In the guidance document, we also highlight a study that was performed that looked at how urine protein dipstick, urine protein to creatinine ratio compared to the albuminuria categories as defined by KDIGO in that previous figure that I showed you. So this allows use of urine dipstick protein to estimate what a potential albuminuria stage is and can potentially increase our ability to detect proteinuria. Moving to cystatin C, in a survey that was performed by looking at the CAP data, in US respondents, only 3.4% had already adopted the CKD-EPI combined biomarker equation that uses both creatinine and cystatin C. 8% planned to adopt it, 32% did not plan to adopt it, and 56.7% were unsure. The most common barriers to adoption were limited testing options for cystatin C. In our lab, we use a third-party reagent on our Beckman analyzers, for example, cost of testing and staffing resources. Now I'm putting this graph up again, and I'd like to direct your attention to the very left of the graph on the very left of the screen, where you can see that essentially the P30, as well as the classification performance of the combined biomarker equation is superior to that of the creatinine-only equation, right? So we have a P30 of 91%, irrespective of what self-identified race category is being discussed, and then correct classification of 68 to 70%. So that kind of answers our question as to why we need cystatin C. It gives us more accurate estimates. But as I mentioned, a lot of providers are unclear about when they should be using cystatin C. So in cases where creatinine is confounded by non-GFR determinants, right, so processes other than GFR or glomerular filtration, we see these processes occurring in patients that have low muscle mass. So creatinine is generated as a byproduct of muscle breakdown. So patients with sarcopenia, amputees, people who are frail or elderly will have lower creatinine concentrations that are not necessarily representative of filtration. Also, people with high creatinine production, so bodybuilders, people with high exogenous creatinine ingestion, and anabolic steroid users. Given the improved performance of the combined biomarker, it is recommended at clinical decision points where possible that you use the combined biomarker equations, as well as using medications with narrow therapeutic indices. I just wanted to touch very quickly on the cystatin C only equation. So this equation was actually developed back in 2012. It only uses cystatin C as a biomarker and does not incorporate a race factor. And this equation has relatively small bias. So the bias is -0.1 and 0.7. and also performs well in terms of the P30 as well as the correct classification, but not as well as the combined biomarker equation as we saw before. It's important to note, as we're advising our clinicians, that cystatin C also has non-GFR determinants, although they are less well studied than creatinine. So, for example, we know that in thyroid diseases, there's actually a bit of conflicting data about hypo versus hyperthyroidism, but we know in thyroid disease, cystatin C levels can be unreliable. People with obesity, diabetes, and inflammation, we may see cystatin C being changed in a way that doesn't really reflect glomerular filtration. Also, there's some conflicting, or rather, it can be confusing, I should say, to decide what a clinician should do in the case that there's a disparity between your EGFR calculated with creatinine and that calculated with cystatin C or the combined biomarker equation. So there is some research, again, looking at cohorts in which there are large differences between EGFR creatinine and EGFR cystatin C, and this is actually prognostic of poor outcomes, right? So increased mortality, hospitalization, and cardiovascular disease. But essentially what this is really telling us is that there's non-GFR determinants that are causing a substantial change in either of the biomarkers, either creatinine or cystatin C. In which case, we'd like to remind you there are a number of other tools that you can use to assess GFR and to assess kidney disease, right? So let's not forget about our urine albumin to creatinine ratio, measure GFR in extreme cases if that is an option, and then 24-hour creatinine clearance. We also encourage clinical laboratorians to become involved in population health initiatives, right? So one of the recent or newly updated, I should say, quality metrics that has been developed around kidney disease is the Healthcare Effectiveness Data and Information Set, or the HEDIS. These are a set of widely used performance improvement tools in healthcare, and they cover a number of different domains of healthcare. So we know that specifically in people with diabetes, it's recommended that they are screened using the kidney profile, right? So your creatinine or cystatin C with EGFR and your urine albumin to creatinine ratio at least once per year. So there is a HEDIS metric that specifically focuses on kidney disease. It's called the Kidney Health Evaluation for Patients with Diabetes. And this metric measures the number of adults within your institution between 18 to 85 years of age with diabetes, irrespective of whether it's type 1 or type 2, that have had at least an annual kidney health evaluation, including EGFR or urine albumin to creatinine ratio. So, based on this recommendation, I decided to try this out at my institution to see whether I could get our nephrologist and our quality people on board with implementing this. So we had an interdisciplinary meeting on kidney disease screening, and I asked simply, how can the clinical lab help, right? So we included primary care, nephrology, quality improvement, as well as operational people from the clinical lab, and very importantly, our Epic architects. So some of the feedback we got was around more clarity in terms of what we report, as well as result comments that can help to clarify test reporting. But we found out actually that a lot of the people who are actually missing a urine albumin to creatinine ratio is because a collection never happened at the lab testing site. So that is something that we can actually influence, right? So looking at this metric at my particular institution, which is Penn Medicine Lancaster General Health, we looked at this KED metric. So these are donuts essentially describing the number of people who essentially had either an EGFR or a urine albumin to creatinine ratio, but not both. So they're not compliant with this metric, right? So you can see that 76.12% had an EGFR done ever, but was overdue. 21.46% never had an EGFR done. So these are diabetic patients that have never had their EGFR computed. And then 2.42% were current. In terms of urine albumin to creatinine ratio, we saw what most people describe, which is that the uptake of the urine albumin to creatinine ratio testing is poorer, right? So 39.54% had never had a urine albumin to creatinine ratio done, and 58.05% had had one done, but it was overdue. And we talked about the reasons, the potential reasons for underutilization of urine albumin to creatinine ratio. So another thing that we wanted to look at was the difference between the proportion of diabetes in our data set relative to the proportion of the population. And essentially what you can see is that Black people in our cohort are overrepresented in this data set, right? One of the reasons why I like, and Hispanic people as well, sorry, I forgot I had the ethnicity on the other side of that slide. One of the reasons why I wanted to point this out is because it could be initially unclear as to why we focus on improving essentially detection of the disease. But essentially by improving detection of the disease, we are actually working towards healthcare equity because a larger proportion of the people who are affected by chronic kidney disease are actually racialized ethnicities and minorities, right? So I have one summary point. It's intentional that there's just one, because if you take away anything from my talk today, it's that clinical laboratorians are critical in improving health equity, for example, with respect to chronic kidney disease. And with that, I will turn it over to Dr. Palmer, who I'm very happy made it over here for her FOSSI talk.
It's okay.
I wasn't supposed to walk away. Okay, you're good.
Awesome.
That should happen.
Wonderful. Thank you so much. Outstanding job. Thank you. So this is going to be interactive, and we've got about 17 minutes together to think about centering laboratory medicine and designing your organization's health equity playbook. So here are my disclosures, our learning objectives. And so you probably found this in your handout. And it's really just to kind of give you what I take away is how one would start to develop your playbook when it's focused on health equity. And the main thing is I can. And so really thinking about what you can do as a laboratorian, as a person, as a member of your own community, and taking action. So one of the quotes that I love is one by the Reverend Dr. Martin Luther King Jr., where it says, all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And so as laboratorians, we actually can make an impact in ensuring that one can actually achieve their optimal health. I don't think I have to share with you what a health disparity is, but not only the CDC, but several other organizations have noted that a health disparity can exist, whether it's the burden of disease, injury, violence, or even opportunities just to achieve your optimal health. And despite us actually studying this for quite some time, we still have populations that experience health disparities. And so I love this image right here that helps you think about what is the difference between equality and equity. And equity just means that you are giving someone not the same thing as another person has, but you're giving someone something that they need to achieve a goal. And in this case, we're talking about achieving their best health. And so I have this checklist that have come up not only by myself, but looking at the literature and thinking about what should be on your checklist if you are an equitable lab. And many of you would say right now that there are a lot of those groups or factors that you've already checked off. But there may be some areas that you really need to take a look at and determine how you can make your lab even more equitable for the communities that you serve. And so communities can look all kinds of different ways, correct? Community can be based off of a place where the individuals live, what their normalities, what do they engage in from a social construct, religion, how do they identify their customs? And so I want you to start thinking about what is the community that you serve, right now in your capacity as a laboratorian, medical technologist, in an in vitro diagnostic company, a CEO, wherever you fall on the spectrum of providing or being adjacent to providing healthcare, how do you describe the community that you serve? And it's a short answer. Sorry. All right, it's getting down to the wire. Very nice. So we've got urban, rural, and college-educated populations, mothers and babies, urban, rural, diverse. Don't usually do this, but I would really like to have the person tell me who submitted college-educated populations. Yes, and what does that mean to you? Uh-huh. Yes. Yes, very good. So that can, and we'll talk through that, but that can impact the way that you may communicate. You may not have to share as much information, and so really being able to figure out the best ways to meet your population. Who said diverse? Very nice. Could you share a little bit on that? Yes. Very nice. Thank you for that. So you've got diversity in geography, and that could include age and how people identify. Very nice. Thank you for that. And so when we talk about fostering health equity, you may also have been posed with the question of how does diversity, equity, inclusion, how do they mend together? How do they work together? Because that may be seen as more of a human resource thing. You know, I get training in this every year, and so I'm not really sure how that really plays a role in fostering health equity. But when we think about what diversity means, the presence of difference, what inclusion means, the act of not excluding, and what equity means, providing people what they need, the question may be,
does any of this have to do with me?
what does any of it have to do with you? So bear with me here. I want to know, what does health equity have to do with you and how you practice laboratory medicine? Because many times we do get tied up in thinking that it's a quality project, it's a passion project, this is something on the side. But what does it really mean to you when you think about that? Short answer here. What does it mean how you deliver care, how you may teach, mentor, conduct research, consult, develop, or even sell products in this space? All right, down to the hour. I like this. So hire came up as something that is a factor. Access, advocacy, don't do everything. Develop, don't do everything. Can someone tell me, was that their answer? No? Practice, routine, talent, teach. Who wants to go for the hire? Who gave hire? Would you share a little bit on that? Health equity in hiring. I love that. Very nice. Thank you for sharing that. And then can someone talk to me about advocacy? With space, who put advocacy? Yes.
I think that if we see our purpose and improving the health of our patients, then we have to address the drivers.
Very nice. Address the drivers. So if we see ourselves that way, we can address the drivers. I like that. Thank you very much for sharing, both of you. So Here we are. You've answered that question. What does it have to do with you? The field of laboratory medicine and pathology can lead in those ways. And as it was just noted that if we start to see ourselves that way, we can start identifying and eliminating these health inequities and health disparities, which may look different depending on where you actually practice. And so here, this is how it's going to impact you when you start thinking through that lens or looking through that lens of health equity. You'll be able to understand the cultural and the health needs of the communities that you serve. So they may be quite diverse. There may be an educational or social, economic status difference. It'll help you understand or even provide you with insights of how to meet their needs. So not meeting the need that you want to meet, but really understanding what they are missing or what that care gap is. It's going to influence your organization's strategic planning and priorities, your budget, your staffing structure, even the test menus, because there may be certain locations that don't need to have the same test menu standardized across the system. However, there may be some needs that could be met, having a test menu that is customized in a manner that's both economically frugal and it's going to have clinical utility. And then it can direct the modes of the clinical laboratory and how it employs its services. So does this warrant point of care testing mode? Does this warrant more of a main lab? And so you will start to then be able to look at your inpatients and outpatients through a different lens of really being able to offer them the care. And so clinical lab operationalizing diversity and delivery of patient care is really something that I picked up from Christina. And so she gave a talk and she really started to dive into each of these areas and how DE&I really can be operationalized. And so several of you here may actually have the ability to capture in your EMR identity. Unfortunately, at this time, we do not. And so when you're unable to capture how someone identifies, that is a major factor of not being able to deliver care in an appropriate manner. So what are their wellness goals? What is the disease incidence? Maybe you have the wrong test menu and you aren't being able to identify in whether they're screening tests or health fairs that allow you to really understand what that disease incidence is. Disability, can we meet the needs of our patients? What about their attitudes toward care? Even coming to have samples collected. What are their attitudes toward care? And that really leads again into capturing your patient's diversity, the use and the documentation of legal versus sex assigned at birth and laboratory information system. And then this equity, and I think many of us do a great job here of figuring out that not only is it important for us to look at the standardization of test menus, but really look at having a standard of quality. And so our patients should not go to one lab versus another lab within the same system and have a lower level of quality. So really standardizing quality in the services that you offer, providing the options for your patients. And then do we have the capacity to really query our laboratory generated data to either identify care gaps in real time or to then provide that information to our healthcare providers? And so I want to just share one example, which comes from a group out in New Mexico, specifically where they demonstrated the value of laboratory information, augmenting a managed care organization's comprehensive diabetes care efforts in New Mexico. And so what they did was that there were patients with diabetes in their system that have to have a hemoglobin A1C and a urine albumin to creatinine ratio done annually. And so TriCore Reference Laboratories collaborated with their Blue Cross Blue Shield group in New Mexico to determine if the laboratory would be able to aid them in being able to ensure that these patients had these two required tests done annually. And what they demonstrated is when they actually queried their own data, leveraged their data to identify individuals who were missing those tests, they actually were able to make sure that those individuals who were required to have the test receive the test. So that kind of makes sense. We're following them, they're going to get it done. So significantly more people in the study group that allowed them to capture their data actually received that hemoglobin A1C test, and they also received the ACR. But I think what is really important here, because I think we'd all agree if we were able to use our data right now, you put someone in a study group, they're in a group, they should do better. But here they're being able to demonstrate to you how much money they saved the managed care organization in penalties. And so when they look to and calculate how much money they saved because their patients then had the 2 tests done, it was over $3 million. And I think that really helps us when we go to the C-suite to be able to demonstrate that there's a monetary value that's attached to it. And we all do know that there is an important value in general for health. I won't go into this one too deeply, but what I want to note here is that there was someone that noted that their community was made up of mothers and babies. And so this group right here, the same group, really targeted at how can they impact prenatal care. And 2 things really came out of this. One is the detection within 24 hours of individuals who had undergone a preterm delivery. And in that, to make sure that the social services were in place, but to also make sure that had they been able to detect the individuals earlier, when you find moms who have high-risk pregnancies, you prevent their babies from going to the NICU. And so they demonstrated that women that underwent, that were in their program, they leveraged their data, they had fewer ED visits, because they were going to actually see their OB at the time, scheduled appointments, not missing them, and which then led them to have fewer preterm deliveries, ultimately fewer neonatal ICU admissions compared to those without the care. So there are so many people out there, right, that are right now engaged in developing health equity initiatives. And so there's plenty of data out there that says that healthcare providers or healthcare executives truly believe that this is the way to go and it's a top business priority. However, there are only about 36% of those that actually have a true agenda with a budget. And so I task you here to ask for the monies. Ask for the things that you need in order to support the ability for you to then carry out the task that needs to be done for health equity. I put this up here because when you do a search for health equity, there was over 12 million pieces of literature that came up when you put in health equity in laboratory medicine. And so many of us are recognizing the role that we can play, and many of us realize right now that you've been doing health equity all along. We're really just putting a name to what you've been doing and highlighting its impact of how you're doing it. We've had several papers out in the past couple of years really highlighting that we can play a role in eliminating health disparities. You may have recognized some of those faces. A study 2 years ago that we conducted with both laboratorians and non-laboratorians weighed in on the question that we asked of, 1, do you even know that what health disparity means? What does health equity mean? And then do you think that lab medicine can play a role in that? And so several questions were asked. And if you look right here, the biggest thing that came out of the questions that we asked, 1 being select the top 5 issues you feel are most important to impact your field. This is laboratorians and non-laboratorians. And they said bias in providing health care. So if non-laboratorians and laboratorians believe that, then we start from that we have bias built into the system. There is a history of bias in the practice of medicine. And so we can ensure how we practice that we start eliminating that bias. Another question we asked is, what are the tools you believe laboratorians have? And this is both laboratorians and non-laboratorians answering that question. Blue being the lab, orange being non-lab, and you can see that data generation. We generate so much data, but the question is, how can we leverage that data? And so building out those partnerships with individuals informatics and making sure that we understand how to use this data in real time or even over time in order to help individuals actually be empowered in living a healthy life. And then how do you think laboratorians can best take the first steps in eliminating health disparities? Well, the data that we generate, both lab and non-laboratorians said, use that data and proactively track for chronic diseases that would help healthcare providers. And also it could be impactful to then prevent acute events. So you can see here ensuring gender and ethnic diversity in new trials or including appropriate curriculum, participating in training, and then again, we come back to making sure that we have the appropriate reference ranges and remove race from those clinical algorithms. So my colleagues and I developed a laboratory medicine strategic plan, and that's published in JALM. And it says diagnose that disparity or their inequity, determine what those variables are that you need, develop your plan, and then identify who those collaborators are to move forward with that. This slide, which is in your handout, just really highlights that even the CDC Prevention Division of Laboratory Systems has key equity health goals that they're focused on to ensure that medically underserved people are getting the care that they need. And then the CDC has noted that racism is a public health crisis. And as Christina noted earlier, thinking about how those social determinants actually impact how one receives care, how they perceive care, and then how they can live a healthy life. Dr. Issa Davis has already talked through guidelines, specifically with the U.S. Task Force, so I won't go into that, but I'll leave you with 2 more slides. This slide I really like because this slide really talks about pathologizing race. And so we talk a lot about race, we talk a lot about medically underserved or minoritized individuals, but it makes the argument here that when we start to use this social construct, we can really start to cause racially biased medicine and harm. And so we see here, which would be your right, algorithms, not only algorithms that are used for EGFR, there are algorithms that are used in OBGYN, there are algorithms used for cardiology, determining if someone should have surgery or not. But there's also algorithms that our healthcare systems are using to determine who gets what care. And so there's a really nice study out in Science that demonstrated just that. So I'm going to move along really quick and ask you this one question. How can the clinical laboratory eliminate these practices? And ask you to engage me just one more time with what we've already talked about and the fact that we do believe that we can make significant changes that will aid individuals to live their best healthy life. What are those things that clinical laboratorians can actually focus on or to eliminate? Understanding your experiences are not universal. Speak up and share. Educate to influence change. Use health data to advocate for policy changes. I like that. Adopt the 2021 CKD. Participate and communicate. And education. I want to ask one person if they would just share with me about the speak up and share. Who said the speak up and share? That's kind of hard sometimes to do. So I'm asking the person to speak up and share. Who spoke up and shared? Okay, what I've learned best in classes is that you don't put people on the spot. So obviously I didn't learn it, I just heard it, so that's my fault. So I want to leave you with this, that I'm encouraged because we've been doing the work for so long. Again, we're putting a name to the work that we're doing. And I encourage you to continue to be that advocate in the laboratory, whether we're patient-facing or not. Clear communication, make sure we're not using limited or biased language, as we do many times have non-public facing documents, and make sure we remove algorithms. Make sure our test menus are responsive, and start to really build out those relationships with individuals that can help us leverage our data in real time. So I will end on that. Yes.
All right, thank you so much for allowing us to hold your attention. We did have some technical difficulties at the start, and then we had to record Dr. Davis's presentation. But I think we pulled it together. If you have any questions, please feel free to engage with us if you do have a few more minutes of your time.
Yes. Yeah. Mm-hmm.
Thank you so much for the lovely session. My question is, in the EGFR story, I feel like folks have gotten this, not using racially correct algorithms. But I things we can't measure within the lab, but how do we optimize our lab testing to drive equity?
Yes. You want to say?
Yeah, that is, you make such a great point because I think, it's often when I engage with clinicians around race-based factors, they're still asking the wrong question, right? So they're still asking, but does this perform better if we remove the race variable? And we're telling them that race is not a thing that you can use to distinctly describe people, and you need to look elsewhere for what is causing this. So, from a lab medicine perspective, I think that we really need to encourage. I mean, I view us to be researchers. I think a lot of us, in the context of academic medical centers, do a lot of research within our practice in addition to our clinical practice. And I think that we need to start learning some new tools, right? So adding new tools to our toolkit to start to interrogate some of those environmental exposures. I mean, we've spoken about, looking at deprivation indexes similar to what we saw in the US renal data system. And really educate ourselves as to how we practice science in a different way. It really requires us to practice and learn a set of different tools that I think that we aren't used to using, and also to develop the informatics strategies to be able to assist us in doing that, right? So it's a start. It's not perfect, but that's what I would recommend. Did you want to add to that?
Yeah, I was only going to say that I think a lot of this has eluded us because we weren't aware that it was being done. It's not the lab doing it, it is our data being placed into these risk algorithms. So for the biggest thing is we can step back and talk to our organization and ask our organization to change the culture of that. So when that science paper came out that literally said that this is the most commonly used software equation to determine how to allocate health services to individuals, but it's based off of dollars. So if Octavia does not have access to care, then I don't have the dollars put in to demonstrate that I have a high burden of illness compared to my counterpart that does. And so when you start to do that, then you think in your community, this could be Black individuals, this can be white individuals, it can be based off rural versus urban, that they're getting better care versus another because of the allocation. So the algorithms are being used in so many ways, but they're trained incorrectly. And so I think that, again, we're asking the wrong question. The question should be what test would allow me to be able to determine the disease status of my patient? Yeah. You were gonna walk up. Yes, yeah.
So, very interesting talks. I guess my question is, about maybe some potential confusion I had with respect to what health race should be incorporated into lab testing or medicine in general. I guess I'm feeling some tension between, do we consider race or do we not?
Yeah, and I've given that talk so many times I decided to abridge it significantly this time. So my apologies. I just didn't want to bore people who come to all of my talks like by saying the same thing over and over again. But essentially, so where you do not use race is to define a study population where you're using it to describe why there is a difference in some sort of health indicator, except, or I shouldn't say some health indicator, that's poor language, when you're connecting it to a biological or a genetic difference. So the takeaway, I guess, is incorporating race or separating people by race without the social context or the environmental exposure context is what I mean. So for example, we can talk about chronic kidney disease, and we saw, for example, that there are a number of non-GFR determinants of creatinine, let's say, right? So thinking through the types of things that influence creatinine, so diet, right? So are there differences in diet, for example, between Black and non-Black people that could explain why there are differences in serum creatinine, right? That's a valid way to use race in the context of research, right? Saying that there are differences in creatinine because there is a genetic predisposition that we don't know about, some nebulous genetic predisposition to having a higher muscle mass that we don't know about based off of a very shady study done 2 decades before, and then therefore having that perpetuated through the literature to have this bias about muscle mass is not the correct way to use it. Does that make sense?
Yeah.
Right, and I think the thing that you need to keep in mind, maybe I'll use sickle cell disease because I think that's clearer because it's monogenic, right? So, for example, we look at people and we say, and I've heard this several times in HemePath sign out. I mean, Mark did HemePath sign out with me. He can verify this back at UVA, where you see a person and you see their race or their name, right? And then it increases your index of suspicion for sickle cell disease or alpha thal, right? Because you know that those are enriched in a particular population. This is where I'm going to throw a curveball at you, right? So my mother is biracial, half white, half black, and my father's biracial, half black and half South Asian. Where do you put me in terms of EGFR estimation? How do you estimate my EGFR? And that is why it's problematic to use race in that context, right? Now, if I live in a community or I live in a society where I'm exposed to disproportionate burdens of socioeconomic factors, right? So you're using race then to describe or to try to characterize some of those factors. That's an appropriate way to use race in terms of research. Hopefully that clarifies it a little bit. So if you're, for example, looking at environmental factors that environmental risk factors that modify sickle cell disease, which we know there are some of those, that's an appropriate use of race.
Yeah, I guess at first I thought you were implying that we should not even ask race if demographics were.
Yeah, so color, that's right. So that's color blindness, right? Which is also not great. Both from a social perspective, I mean, color blindness is not a real thing. Of course, we see color, we see that we look differently. And being colorblind erases people's identity. And, you know, being colorblind is also a privilege because I never forget every day when I wake up that I'm black because it determines a lot of what happens to me in my life, right? And there are people who don't have that same experience where they don't have to think about the color of their skin because it doesn't, right? So that's from a societal perspective. From a clinical perspective, I think it's still important to consider race towards the goal of eliminating health disparities. I think what has happened, though, is because there's that confusion between the genesis of race or what it describes, it has resulted in us changing the way that we manage patients, right? Based on race. And that gets a little bit tricky because if you're saying that somebody responds to a drug differently because of the color of their skin, that's problematic. Yeah. Does that make sense? Is that a bit clearer? Okay. Yeah.
India, we don't have a specific EGFR formula.
Yeah.
But whereas, Chinese population, there has been
Yeah. Mm-hmm.
CKDPI, there has been one CKDPI formula for
Yeah.
and one for Bangladesh.
Thank you. Yeah. This is such a good question. So these equations, the thing you have to remember about all of those metrics we talked about, so the P30, the bias, as well as the clinical validation piece of it, is that it's specific to the population in which it was studied, right? So the paper that presented, where we saw the P30 of being 87 to 86%, I think, and stuff like that, that is specific to that particular validation and then development and then validation cohort. So you can apply that same model or that same equation to another population and have slightly different metrics, right? So they developed that in a representative cohort of people who are African American. It was a multi-site cohort, so it's representative of the U.S. population, right? This is one of the things that is tricky. It's like using population level data is a double-edged sword. It's useful from the perspective of you being able to, develop trends and power your study sufficiently to detect trends and develop models. But on the other hand, when you start to look at individual patients or when you start to look at locations that have different demographic characteristics or different social characteristics, it doesn't necessarily hold up. So you need to test and then validate and make sure that it performs well in different populations, essentially. And that's not limited to EGFR, right?
Can we get her? Can we try her one? Okay.
Oh.
Yes. Mhm.
Were you saying that someone would look at the label of a slide and not think that it's sickle cell because they didn't see whatever they were looking for in the name?
I'm saying that sometimes we would consider somebody's ethnic origin in formulating what our diagnosis or in thinking through what a possible diagnosis could be. So we look at the red cell indices, we look at the smear, we look at the hemoglobin electrophoresis, we see, increased hemoglobin A2, and we're like, okay, this person is from Thailand, and you may be more inclined to think of alpha thal, which is something that's commonly done in race. And there's actually some studies that were done in essentially medical education on some of the common themes where race is misused essentially or incorrectly taught. And one of them is in that context, right? So thinking about, I think you could refer to it as disease branding.
Yes.
Where you think about a particular disease as being prevalent in a particular population. Unfortunately, you can't tell whether a sequence of DNA is present in someone by looking at the color of their skin. We know historically the protective functions of the sickle cell allele in the context of continental Africa and South Asia in terms of malaria. So we know that people of recent African ancestry may be more likely to have that gene sequence. But again, how can you tell just by looking at the color of someone's skin? I always use myself as an example as somebody who has a lot of mixed race, but I tick black on my box when I identify my race, right? So I guess where does that put me in your diagnosis? Or if, for example, I marry somebody with a very quintessential African name, but for example, the person is white. That's why that type of practice is really ill-advised.
Yes.
Exactly. It introduces bias based on a skin color, a name, an eye color, somebody's physical appearance that fails to capture their genetic makeup. You just simply can't tell, right?
An observation as a machine learning software today, talking about validating the algorithms generalize across all your patient groups, right? And it occurred to me, we don't have that recommendation for general validation framework, right? So what would health equity validation look like?
So I would say we do. So I would say that when we have the assay, it's told CAP or whoever your regulatory body says that you need to validate it within your own population. Now, many of us don't have the babies. We can't do the 0 to the 1 and the 30 to the 6 months. So what do? We do a transference study. And so, and we say that the transference that we're doing is because the original study was done in a population that looks like it is similar to the population that we serve. But I think that we've gotten over that by using a transference because we just don't have the ability to do that study. And that's one of the things when we think about assessing the community that you serve. What is the community that you're serving? Because you may be serving a more homogeneous community, but then you're forgetting that you may have another population that utilizes your ED or another population that's only coming into your cancer center because they're coming from out of state. You have a specialized. And so it looks like you looking at the population that you serve and then making sure that whatever type of interpretation or testimony you have is responsive to the needs of that population. And a lot of people are like, well, how many Black people do I need to have in it? How many people that identify as Indian or Asian? And do I have to go beyond, like, individuals identify as Puerto Rican? We just need to know what is the population that you serve, because the sodium is going to be the same in anyone. An HCG, if you're pregnant or not, it's going to be the same in everyone. What we're trying to determine is what is either that medical decision limit that's going to help then aid in your diagnosis, your treatment, your follow-up, your therapy. And I think that's where we're getting hung up on with the race component, is that we have to unlearn what we've learned. So remember that EGF paper was based off of 4 papers. One paper that it cited was a paper that was in children. The second paper that it cited was a paper that was in a Caribbean group and a European group that was in the same group, and they looked at potassium levels. There was never a real true measurement of muscle mass, if that was the case. And then there's been other papers that have demonstrated. And you asked a really good question, the person behind you too, that when you think about the equation that we currently are using, even populations that were African populations, it didn't even work in that population. But it was supposed to work in a Black population that identifies as Black in America. So I think that when we think about equity, you just think about that population that you serve. And that. And I think we may have been in the same talk, but there was a second talk also about that when it came up to the machine learning. Steve Masters gave an example that the machine learning said that asthma is protective for people who are coming into the emergency department who have respiratory failure. Well, if you come into the department with asthma, they know it's asthma, you're getting the best care. So you're getting moved quicker, you're getting the medicine that you need, you're getting follow-up. It's not that it was protective. It was just that you were an asthmatic, you came in with your inhaler, they knew what to do, whereas a person that was coming in with some type of respiratory distress, they still had to figure out what it was. Was it something from the environment? Was it something that you ate? And so we can make machine learning answer any question that we want. And so we just have to be careful when we start to think about using machine learning or what we built into algorithms, and we really want to just do individualized care. So at the end of the day, if the EGFR is not serving you, as my nephrologist has shared with me, is that they're going to order other tests. They don't need an estimation of someone who they can look at that's decomposing. And we have a really good case report from my resident where we demonstrated that a Black woman was she was in decomposition, for a whole year. And because they followed that EGFR, she had not hit below 20 on the Black equation. They continued just to have her come in and follow her EGFR. And so delayed of transplant, delayed of even getting dialysis. So now she's on the transplant list. So it's those type of things that we have to unlearn what we've learned, and deliver individualized care, and then tell them to stop using these equations. These are great questions. I don't know if you guys know, it's 4:23 and we can't thank you enough for being here. We can talk. We want to know what you think. We're happy to have a two-way conversation, but I just wanted you guys to know what time it was, because we thank you for that.